So hi, everybody. I'm Greg Brown. I'm going to give a broad overview of suicide prevention research for implementation researchers. And the rest of you, if you're not an implementation researcher, you can listen in. So there's four broad learning objectives. One is to describe suicide data and reporting resources in the military, to describe the nomenclature for self-directed violence, to review selected suicide-related outcomes for clinical research, and finally, to review some risk management protocols to consider when doing clinical trial research. So the primary source of information to the public on suicides is issued every year in an annual suicide report by the Department of Defense. This is the official DoD counts and rates that are made available to the public, and also reports on trends over time, which may be an indication whether or not certain program and initiatives are having the desired effect. In calendar year 2020, there were a total of 580 service members who died by suicide, 384 in the active component, 77 in reserve, and 119 in National Guard. Typically, suicide member descendants were largely enlisted, male, and less than 30 years of age, regardless of military population. So if you look at suicide rates, which is the way to look at suicide data so you can compare across groups or over time, there has been a statistically increase from calendar year 2015 to 2020, from 20.3 to 28.7 suicides per 100,000. Whereas in contrast, there was no significant increase in the Reserve or National Guard. So the method of suicide is by and large by firearm, and that ranges from 64% to almost 80% in the National Guard. And people by and large overwhelmingly use personally owned firearms to kill themselves. The second method is hanging or asphyxiation, and then the other methods are much less occur much less often. So the other major source of information is what's called the DOTSR, the Department of Defense Suicide Event Report. That's also issued every year. This is the 2019 annual report that is most recently available. So the DOTSR is a web-based system for collecting, organizing, and securing a standard set of case-level data for each service member on suicides, suicide attempts, regardless of military service, component, or duty status. I list the portal for the system there. It includes guides that MHS or command level appointees on data to assess and collect, as well as potential resources for required information. The DOTSR form assesses almost 500 data elements that are available for research. These include personal military information, and especially event information related to the suicide or suicide behavior. The DOTSR also includes data on suicide attempts, whereas the annual suicide report does not. The data on suicide attempts indicated that for calendar year 2019, 1,462 suicide attempts were recorded by 1,388 unique individuals. There were 33 individuals who submitted a DOTSR form in 2019 that had more than one attempt. Among DOTSR forms, 57 had at least one current or past behavioral diagnosis in their medical record. And for active component service members, suicide and alcohol overdose was the most common method of suicide attempts, accounting for 53% of the reported suicide attempts. So this is quite different from what we see in suicides. Suicide attempts largely occurs drug and alcohol overdose. And then regardless of whether or not an individual voluntarily disclosed or was assessed for suicidal thoughts, feelings, or behaviors, approximately half of all individuals who died by suicide in calendar year 2019 made contact with the military health system in the prior 90 days. So the official nomenclature that has been adopted by the Department of Defense is the Self-Directed Violence Surveillance System that includes uniform definitions and recommended data elements. This was put together by the Centers for Disease Control and Prevention over about a 10-year period. Many of us were on the advisory board that helped to develop these definitions. And so I would strongly suggest that you be very familiar with each of these definitions of suicide behavior. Looking at kind of a flow chart for the various definitions, we start with the broad category of self-directed violence, and then there's 3 subtypes, including suicidal self-directed violence, undetermined self-directed violence, and non-suicidal self-directed violence. And these can include fatal violence, including suicides, or non-fatal self-directed violence, including suicide attempts or other types of suicide attempts, such as suicide attempts interrupted by self or others, as well as other suicidal behaviors, such as preparatory behavior, like making a will, buying a gun, and so on. So I'm going to take a deeper dive into these definitions because it's really important that you understand them so you know what you're looking for when you're measuring outcomes. So the formal CDC attempt definition is a non-fatal, self-directed, potentially injurious behavior with any intent to die as a result of the behavior. A suicide attempt may or may not result in injury. So if somebody is intent on killing themselves, puts a gun under their chin to pull the trigger, but it misfires, there's no bullet that was discharged, that would be considered a suicide attempt, even though there was no self-injury. So some of the time, when you assess suicide attempts, it's fairly straightforward. You ask, have you made a suicide attempt? And the person says, yes, I took a whole bottle of pills because I definitely wanted to die. This answer includes that the behavior was lethal, took a whole bottle of pills. We consider that probably lethal. It includes intent because the person said, I definitely wanted to die. And the intent and act are linked. And it's really important that you carefully look at each of these components and discern whether or not each thing occurs. And I got to tell you that often the most difficult way of determining whether or not somebody attempted is whether the behavior was lethal or not, or potentially lethal. So if somebody steps, a good example of that would be somebody who goes up to the bridge, gets ready to jump off. Is that considered a suicide attempt, a potential attempt, or not? And it really depends on where the person is standing. If they're over the rail in that little 3-inch gap, and they could easily slip off, that's potentially lethal. If they're on the sidewalk, that is probably not potentially lethal if they're not going to get hit. But anyway, you can see how it can be very tricky in discerning whether something's potentially lethal or not. And this is where we have most of our discussion around is determining the lethality of the behavior. Okay. Often suicide intent can be inferred from the behavior or circumstances. So if the individual thought what they did could be lethal, even though it probably was not, we would probably say that implies intent, and then therefore classify a behavior as a suicide attempt. So this occurs most often in adolescents. Say they think that 3 Tylenol is going to kill them, which it wouldn't, but they actually believed it would kill them. So we would probably classify that as a suicide attempt. Or there can be a clinically impressive circumstance of a highly lethal act, such as a gunshot to the head or chest, jumping from a high floor, setting oneself on fire, or taking several hundred pills. All those we would consider highly lethal, and we would override what the person is saying because we can infer, gee, that this definitely looks like a suicide attempt. I've actually talked with patients who have shot themselves, and there was no way it could be accidental because they took a rifle and they turned it around and put it with the barrel to their chest and pulled the trigger, and it ricocheted around the rib cage. And the person denied it. They said it was an accident, but we would infer that that was actually suicide behavior. Okay. The definitions, the CDC definitions also include terms that should not be used. And I point these out because if you say most of these terms in a grant application, you're going to be outed for not being have an understanding of the various terms that are accepted in research. So you want to stay away from terms like suicide gesture or manipulative act or failed attempt. All those are terms which should not be used. So having said that, in your research, you want to choose an appropriate suicide outcome domain. These can include suicides or death by suicide, suicidal behaviors such as suicide attempts, or suicidal ideation. So if we look at each of these domains separately, if you look at suicide as an outcome, the pros of that as an outcome is there's high ecological validity. If you can have some impact on suicide, death by suicide, that's going to go a long way for your study. There's currently a national, state, and DoD data sets available for looking at suicides, including the National Death Index, NVDRS, and the DOTSR. The cons is that suicide is a rare event, even among high-risk populations. And so what's usually required is very large samples to detect any effectiveness of the intervention or implementation strategy that you're studying. The second is that discerning the cause of death can often be challenging. This is particularly the case in distinguishing suicides from accidental overdose. And finally, ascertaining death by suicide could take a long time. Sorry. So the National Death Index works with the state vital statistics offices for establishing a database and resource for mortality ascertainment. These include death records from all 50 states, New York City, Puerto Rico, and the U.S. Virgin Islands. It also includes recent data from out-of-country deaths of military personnel. It includes belated records. And typically, the full NDI file is available 11 months after the calendar year. And you got to take that into consideration when you're designing studies on the length of time it's going to require to do an NDI search. When 90% of the data is available, NDI does have an early release file that can be used. So the next domain is suicide attempt as an outcome. The advantage here is that suicide attempts may serve as a proxy measure of death by suicide and may be assessed by either self-report, clinician interview in format, or by using a database such as a medical record database that might use ICD-10 codes. It occurs more frequently than suicide, so that's a good thing because you can power your studies, but maybe especially rare among older populations who often kill themselves in the first attempt. Suicide attempts suicides can also be difficult to identify, whether there's questionable lethality or potential lethality or questionable intent to die. And so this is where it's important, if you're doing research assessments of suicide attempts, that you use blind assessors to prevent biased assessments. I will say that if you're doing some type of intervention research, it's easy for the assessors to become unblinded. So it's important that you measure whether there's a break in the blind. So in looking at suicide behavior as an outcome, you need to determine whether or not you're only going to look at suicide attempts or whether you're going to look at other types of suicide behavior, such as interrupted self-directed violence by self or others, or preparatory behavior. Or some researchers have looked at ED visits for suicide-related concern, and that's also tricky to interpret that data because whether or not the ED visit is a positive or negative outcome needs to be considered. It's important to use validated measures of suicide behavior that correspond to the CDC nomenclature. And when you're administering these measures, it's important that you establish inter-rater reliability or consider using a blinded adjudication board for classification of undetermined behaviors. And finally, consider the ascertainment of suicide attempts using existing databases, as well as self-report clinician-administered measures. So they're not perfectly congruent, whether or not you ask somebody about behavior or whether or not it's retrieved from a database, but there's advantages to having both types. And I kind of like to think of the data kind of like a Swiss cheese. If you put layers of Swiss cheese, you're filling up the holes with the Swiss cheese and can get a more complete picture of the impact of your intervention or implementation.
Suicide attempt self-injury interview was developed by Marsha Linehan and colleagues, including myself. It assesses all kind of aspect. It treats each suicide attempt as an event and looks at all aspects from the kind of triggers, what set it off, what specific behavior was it, what were factors that were happening simultaneously, such as use of alcohol, writing a suicide note, and the kind of medical treatment and physical condition afterward. And it's got scores that you can build from this that look at things like risk rescue, possibility, how much was intent to die part of the event. And it also allows classification of non-suicidal self-injury versus what is called an ambivalent suicide attempt versus a non-ambivalent attempt. So in most cases, ambivalent attempts and non-ambivalent attempts and failed suicides are all classified together as a suicide attempt, but it's very helpful when you're actually assessing with participants to be able to distinguish an ambivalent attempt from a non-ambivalent attempt. It gives them some clarity. There's also a suicide attempt self-injury count. That's a short form version of this that is that is based on all of the interviews, rating scales from the full interview, but much briefer version, so you can assess all attempts in a much shorter period of time.
So the SASE does use standardized definitions of suicidal and self-injurious behavior. It's important that it assesses the suicidal intent of an act independent of the form or consequences of the act itself. Reliability, validity, and sensitivity to change have been established in treatment outcome studies. So once you can also consider suicidal ideation as an outcome. The pros of that is that it occurs more frequently than attempts. It may be assessed by clinical interview or self-report. There are many validated measures of ideation of behavior, of suicidal ideation available, and there are subtypes that can be classified, as I mentioned, using the Columbia and other measures that do the same thing. So probably one of the most commonly used measures in adults is the Scale for Suicide Ideation, which is a 21-item interview administered scale that measures the intensity of patients' specific attitudes, behaviors, and plans to commit suicide. The first 5 items are screening items and include things like wish to live, wish to die, and a desire to make a suicide attempt. If somebody scores positive on the screeners, it's followed by 14 items to assess suicidal risk factors. The last 2 items also assess suicide attempts. Typically it's done in 2 ways. You can either ask about suicidal ideation on the day of the interview or in the recent past, but you can also look at the most severe point of ideation, which has been shown to be highly predictive of suicides at follow-up. If you look at the most severe point in the person's life. Each of the items is rated on a 3-point scale ranging from 0 to 2 according to suicidal intensity, and it's scored by summing the items. The SSI is brief, low burden questionnaire that has been widely used in clinical trials. It's sensitive to change with good convergent validity, integrated reliability, internal consistency, and so on. And these measures, I just am cherry picking some of them, but you can look in the phoenixtoolkit.org with that link there, and it describes various other measures that are available for in the suicide ideation and behavior domain. There was a study done by Pete Gutierrez, Thomas Joyner, and their colleagues looking at the clinical utility of these measures and the implications for military suicide risk assessment. They administered the Columbia Suicide Severity Rating Scale, the Self-Harm Behavior Questionnaire, the Suicide Behavior Questionnaire Revised, and then the Scale for Suicidal Ideation. This was done with 1,044 military service members who completed the baseline assessments and were followed up to 3 months. But what the study found was that there was no best measure of suicide risk assessment, and clinicians are therefore encouraged to pick their measure that most suits their needs. Finally, I got to mention ideation as an outcome. There are several cons to selecting this domain. This includes that the severity or intensity of ideation can be highly variable over time. There's often a regression to the mean that happens in clinical trials. The ideation can be fleeting, short or long duration. It can be chronic or acute, and it can be stable or highly variable. It's also subject to recall bias, and some researchers have used real-time monitoring, such as ecological momentary assessment. I give the citation there, which is interesting because they found that among people who denied suicidal ideation using the SSI, retrospectively in the past week, the EMA picked up instances of ideation. So you're more likely to capture suicidal ideation with EMA. Finally, secondary gains or losses can greatly influence self-report. If somebody desires hospitalization, obviously they're more likely to admit to risk, or if they fear hospitalization or loss, maybe deny. And the other problem with self-report measures is you need to assess whether or not the participant is blind to the assigned study condition. The other thing that happens with ideation is that it can be highly skewed. And so this is data from the SSI during a follow-up in one of the trials that we did with suicide attempters. And you can see here what we call an L-shaped distribution, a lot of zeros, a couple low scores, and then a big tail. And so that becomes a problem when using parametric statistics, non-parametric statistics, and you likely will have to, we couldn't even use Z transformations. We had to categorize the suicide ideation to look at the effects of the trial. If you look at the worst point, you can ask somebody, since the last assessment, describe your ideation since at its worst point, and you can see if we measure that, the distribution is much more starting to approach a more normal curve, or more likely a Poisson distribution here, but much more likely to analyze ideation at its worst point along a continuum. Another aspect in conducting trials is determining how you're going to use suicidal ideation as inclusion criteria. You need to consider enrolling patients with a history of ideation, but you have to be careful about what time frame of the ideation, the day or hour of the assessment, whether or not it occurred in the past week, the past month, or lifetime, and use clearly defined and reliable thresholds for the severity of ideation that have evidence-based cutoff scores. You want to avoid using vague and unreliable nomenclature such as significant ideation. With suicide behavior, you need to estimate the rates of behavior during follow-up in the intervention condition and in the control condition. And in general, larger sample sizes are needed when measuring suicide behavior to determine if the intervention is effective. You want to be careful about whether or not you have enough suicide attempts that occur during follow-up in your trial so that you'll be able to detect effects. So you'll make sure it's adequately powered. One issue that researchers run into is kind of balancing the increased sample availability with the power to detect effects during follow-up. And in general, if you have a lower threshold, such as a longer time frame for assessing behavior or ideation, there could be decreased rates of suicide behavior during follow-up, which affects your power. But then if you try to increase your power by increasing it would be more likely that people will attempt during follow-up, you can run into problems with feasibility of recruitment. So it's important that you carefully consider these kind of juxtaposed tension when selecting your enrollment criteria. So the final thing I want to talk about is managing participants with suicide risk in clinical trials. This includes what to monitor, how to monitor, and what should be done if suicide risk is detected. So it's important to recognize that risk management occurs throughout the trial. This includes the initial contact or screening, the time between the screening and the baseline visit or consent, and also prior to randomization. It includes during the clinical trial as well as the end of participation. The risk management procedures should be similar throughout the trial as well as across both conditions. So it's important that you assess risk, including the increased frequency or severity of ideation, including the occurrence of suicide intent with a specific plan, the occurrence of any suicide behavior, or an increased frequency of severity of symptoms associated with suicide behavior, such as increase in depressive severity, hopelessness, or substance abuse. It's important to define the risk criteria and procedures for monitoring risk prior to enrollment and specify the action plan if that risk is met. So when you're doing risk assessments, it's important to get the phone contact each and every time that you speak with somebody, if you're doing it by phone or telehealth at the beginning of the interview, as well as their physical location in case they need to be rescued. Have a full discussion with participants about emergency procedures that may be used with study staff as for acute risk management. And there should be a written documentation of emergency procedures and study-specific contact information. And I think nobody likes to be carted off by the police in handcuffs, at least not many people do. And so it's important to have a thorough discussion about what actually happens if somebody needs to be rescued for their own safety. Okay. Next slide. Okay, all staff should have suicide risk assessment training, including participatory role plays where the staff is working with a patient who becomes suicidal. Written procedures should be provided, and for phone interactions, staff should have a way to connect with the senior investigator or emergency services without any of the call. And sometimes what we've done is employ 2 separate phones, so we don't even have to put somebody on hold. We can just keep that person live while we call the other number. And we've even trained people to, if they're on the same floor as us and we're doing an in-person assessment, to how to step out in the hall, grab somebody to go get somebody who can help with risk management. A senior investigator should always be available for staff for consultation, and encourage consultation rather than staff managing the risk on their own. Just encourage a atmosphere of having these huddles and getting together to discern and manage risk. And we do have a buzzword we use. We say, instruct staff to say, "I have an emergency." And if I hear that, one of my staff say that, I kind of drop whatever I'm doing, focus my attention on helping this person with the emergency. So make sure you do use these important terms to kind of alert everybody that there's an emergency situation happening. Dr. Waltzer and colleagues have developed a therapeutic risk management procedure that includes suicide risk stratification by severity and temporality. So this includes low, intermediate, and high severe thresholds, as well as acute and chronic types of ideation. This kind of format has been described in the VA DoD clinical practice guidelines for the assessment and management of patients at risk for suicide. And they include both guidelines for acute risk and chronic risk. Here I present the acute risk, including the essential features and the corresponding action for each level of risk. So for high risk, these can include, the essential features may include suicidal ideation with intent to die, or an inability to maintain safety independent of external support or help. These may include also a plan for suicide, a recent suicide attempt or PrEP behavior, or any acute major mental illness or exacerbation of a personality disorder. The corresponding action for high acute suicide risk may be to consider psychiatric hospitalization to maintain safety or aggressively target modifiable factors. And these individuals may need to be directly observed until they are transferred to a secure unit and kept in an environment with limited access to lethal means. Most of the time, you're dealing with intermediate risk, and so this includes any suicidal ideation to die by suicide. It includes the ability to maintain safety and independent of external support. These individuals may present similar to high suicide risk patients, but the only difference is that they may lack intent, or they may have an identified reason for living, or they may abide by following a safety plan or crisis response plan to maintain their safety. And you may also consider psychiatric hospitalization as a way to address safety, but you can also consider outpatient management of suicidal thoughts and behaviors by increasing the frequency of contact, regularly reassessing risk, or developing a collaborative safety plan with the person. And finally, for low risk, I won't get into all that, but there are the definitions there and the corresponding action that can be taken. And finally, I think we have to say that postvention is also important. This can be incredibly challenging in conducting trials with at-risk individuals. And so procedures should be established in advance should a suicide or highly lethal attempt occur during the trial. You want to, of course, follow severe adverse event reporting guidelines per the IRB or the DSMB, but it's really important to provide emotional support for staff. And it could be very, we've had people in tears, and it could be very upsetting when somebody is in your trial makes a suicide attempt or kills themselves. You also want to talk about how contact with family will be handled in the event that there is a suicide. I also want to point out a couple of other great resources. This is a webinar conducted by Marjan Holloway and Kay Kamtwa on conducting research with high-risk individuals. The link is there, sponsored by the MSRC. And then finally, there is a great webinar done by Megan Rogers on designing completely online studies for suicide prevention, and the link is there. And I think I made it through the talk.